are more than 0.5 centimeters, they are the bulla. Wheals, particularly, they are seen in urticaria. These are the erythematous raised skin lesions, and they disappear within 24 to 48 hours. Then are the petechia, they are the pinhead-sized macules of the blood. And the purpura, they are the large petechia which do not blanch on pressure. And then we have the ecchymosis. In this, there is large extra. So these are the viruses which we will be discussing today. So the most common viruses causing the maculopapular rash are the measles, rubella virus, then parvo B19, then HHV6, and then Coxsackie virus causing HFMD. And in vesicular lesions, as we all know, the most common is the VZV, and then the HSV. And then pustular regions are caused by the Mpox virus, and nodular region by the papilloma and by the molluscum contagiosum virus. So two definitions we need to know when we're dealing with rash. One is exanthum, another is enanthum. So exanthum is something that is rash but which appears abruptly and it affects several areas of the skin. So it is something called breaking out. Another is enanthum. Enanthum is something which is there's eruption on the mucous membrane. So exanthum is on skin and enanthum is on the mucous membrane. So let's discuss the first case. Anita, she's a 4 previously healthy girl presents with 1 week history of cough, runny nose, fever, sore throat, and red eyes. Yesterday, she developed a red rash which started on her face and then spread to her trunk. She has never received any vaccination. And on skin examination, the child is ill appearing and there is morbilliform rash with erythematous macules and papules. The lesions the rash has spread to trunk and extremities. So anyone out of you can you please say what disease it can be? Any student, any
Measles. Can I add on?
am I audible? Are all the participants?
Your voice is breaking, ma'am.
And now you're audible.
Okay, okay, fine. So we are dealing here with these are
No, your voice is not audible again. I think there is
these are the Koplik spots. Here with the I think somebody said also we are dealing here with the case of measles. And in measles, we have to see there are 3 typical points. Number 1 is fever, that is high grade fever, then rash, and then at least one of these 3 should be present, either cough, coryza, or conjunctivitis. One of these 3, and then fever and rash. So these are the typical clinical definition as per CDC. So the rash in measles, it starts on the face, at the hairline, or behind the ears. So hello. At the hairline or behind the ears, and then it spreads downwards through the neck, trunk, and rash. The rash are usually not itchy, and Koplik spots, which are pathognomic, they may or may not be seen. So on the lighter skin patient, it is easier to see these rash, and in the darker skin, it can be seen as a hyperpigmentation. So this is the measles timeline. So this is important, very important slide. So initially, the blue part of the slide, this is showing the incubation period. It is about 7 to 21 days. So day 0 is the day of rash, and the symptoms, the prodrome symptoms, they appear 4 days before the rash has started. So patient will have fever, the 3 C's which we have seen, cough, coryza, conjunctivitis. The patient will have those things, and the Koplik spot. So eventually the fever subsides a little bit, and then the Koplik spots also subside, and then there's the appearance of rash, the maculopapular rash. So the patient of measles, it is important to note here, the patient of measles is infectious 4 days before and 4 days after the rash. So coming on to diagnosis. So diagnosis is by serology. In serology, we do IgM testing. This IgM testing is done on the serum sample. And then we can do the IgG testing. In this, we have to see the 4-fold rise of IgG. And then we can do the PCR testing also. In PCR, we take 3 samples. One is the oropharyngeal or nasopharyngeal samples, then throat swab and urine. On these 3 samples, the RT-PCR, they can be done. And obviously, the PCR sensitivity and specificity is more. So for ELISA, we are taking the serum samples. For PCR, these 3 samples, they can be taken. So 10 to 15 ml of urine and ml in VTM, they should be transported to the lab. So for interpreting the result of measles, it is very important to take the history of the patient if he has taken the measles vaccination recently. So because measles vaccination, it can also interfere with the IgM results. And also to take into account the epidemiological context that the patient has contact with another known patient of measles. So in areas where the number of measles and rubella patients are less, so these 2 things are very important. So there are certain complications, like 20% may be hospitalized and there may be death in 1,000 patients. So another serious complications of measles is SSPE, subacute sclerosing panencephalitis, and it is a fatal disease, and death typically occurs within 1 to 3 years of diagnosis. So there is no specific treatment. So vitamin A with consultation with the ID expert. So next disease, hello. Am I audible? Is it okay?
Yeah, you are audible, but sometimes the voice is breaking. Now it is audible.
Okay, fine. So next we are dealing with the rubella case. So in rubella, the characteristic rash is maculopapular rash. It starts from the face, as we have seen with measles. It will spread down the body and it generalizes within 24 hours. So the difference here between the measles and rubella is in rubella, we will see lymphadenopathy. And this, it precedes the rash. It will come before the rash, the lymphadenopathy, right? And the clinically, acute onset of generalized rash, that is maculopapular, then the fever, and then either of these 3, that is arthralgia, cervical lymphadenopathy, or conjunctivitis. So these probable cases, as we have discussed, any of the clinical criteria, then the positive IgM, or if the patient lacks the presumptive evidence of any rubella immunity and the patient has not taken any rubella vaccination. So confirmation again, the lab confirmation. In this again, we have the IgM testing on the serum sample, and then IgG, there has to be 4-fold rise. And for the RT-PCR, we take 3 samples, that is throat swab, nasopharyngeal swab, and the urine swab. So this is similar for both measles and rubella. And in rubella, we do something that is the avidity test. So if the avidity is low, it is a recent infection. If it is or it can be due to the vaccination. So these are the basic tests, and these are about the fever with rash and the viral infection. So I will just skip the slide. So 8-year-old male, he was brought to pediatrician by his mother because he developed low-grade fever several days ago and now has red cheeks and a new rash on his body. I think everyone can get this. The patient is edematous marks on the cheek, and classically it is a slab cheek appearance. So this is erythema infectiosum caused by parvovirus B19. Typically, it occurs in 4 to 10 years of age, and there's the slab cheek appearance. Then there is exanthum, that is maculopapular rash on trunks and extremities. And when the disease, it waves off, then there is lace-like reticular rashes on the body. So it is typical of erythema infectiosum, that is the slab cheek appearance. Measles, rubella, and then the parvo B19. The next case is written 6-year-old male. Mother is concerned because he developed low-grade fever, painful ulcers in mouth, and rashes on his hands and feet. No medication was given, and he is up to date with the vaccination, and he attends the elementary school. So this case is also showing clearly that there are particular rashes on mouth, hands, and feet. So the rashes, they are superficial, round erosions on the tongue and soft palate. They are 3 to 7 mm, oval-shaped vesicles with erythematous halos on the palm. So we are dealing here with a patient of hand, foot, and mouth disease. So the prodrome here, the patient initially has fever, sore throat, and malaise, and eventually the lesions is like lesions, and eventually the patient will have lesions on hands, foot, and occasionally the lesions will be seen on the buttocks, elbows, and on knees also. The causative agent of HFMD is Coxsackie A16, A6, and Enterovirus 71. There are various other strains also. These are the most common strains. And if the patient is having Enterovirus 71, we need to take into account that this may cause aseptic meningitis or encephalitis. So it is a self-limiting disease. So next case we are discussing here is Viraj, 11-month-old male, presents with the fever and rash, and his mother noted a high-grade fever. He appeared well, was eating well, and after that, the fever resolved, and eventually the patient developed a red rash. So here, the patient is having high-grade fever, then eventually the fever subsides, and then the patient has rash. This is a typical history of roseola infantum, caused by HHV6 or sometimes HHV7 also. This mostly occurs in the patient who are less than 2 years of age. So there is abrupt onset of high fever, and then the patient develops an exanthem. That's why it is called exanthema subitum. That means sudden rash. Now, because of the high fever seen here, the patient may have febrile seizures also in this case. So the patient of roseola infantum, we need to take into this account. So the Nagayama spots are seen, but these are not pathognomic for this. So this is also a self-limiting disease, just the febrile seizures that need to be taken into care. So then now what diseases we have discussed are the measles, rubella. So the lesions start from the face, spread to the body, and then in the measles we have 3 C's. In the rubella we need to see the lymphadenopathy on hand, foot, and mouth. And erythema parvo B19, it is a slack cheek appearance. And in roseola, there's a high-grade fever goes, and then the rash comes. So these are the typical maculopapular rashes. Now we come to the vesicular rashes. So the typical one is the chicken pox. So in chicken pox, I think all must be aware of this fever with rash condition. So the rash and the fever, they appear on the same day almost. And the rash, there is crop of rashes, that is vesicle, papules, macules, all are present together. So this is the hallmark of chickenpox lesions. And the lesions of chickenpox, they are pruritic and they are vesicular. So these and the spread is from trunks to extremities. As we have seen in measles, it was starting from the face, but this vesicular rash of chickenpox, it is going to start from the trunks and then it will going to spread to the extremities. So there's typical dew drop on the rose petal appearance, right? So this slide is showing the typical features of the chickenpox. So then another complication of chickenpox, if it gets latent into the dorsal root ganglion, the patient develops herpes zoster. And in herpes zoster, when it starts, there is a faint erythema in the distribution of the intercostal nerve, the nerve which is basically it affects the nerves. So initially it will be a faint erythema, and eventually there will be a typical mature rash with regular vesicles. There are vesicles, and there will be an erythematous base over there. So the most common dermatome involved is the trigeminal nerve, the various branches, ophthalmic, mandibular, and the maxillary branches of the trigeminal nerve, it is involved. So treatment is the acyclovir. So next comes the pustular rash. The recent one is the mpox virus. So the transmission is from the animals to humans by bat bites or the scratch of the animals or consumption of the bush meat. There can be secondary transmission from human to human. by respiratory droplets. So in this, the initial incubation period, there will be no symptoms. So this is the primary viremia. The virus is in blood. And eventually there will be febrile stage. In this, we have fever. And the typical point to remember in mpox is that we have swollen lymph nodes here, right? And then the rash, it is centrifugal. This will start from face, then trunks, and then will spread to the limbs. So unlikely of the chickenpox, which starts from the body, it starts from the mpox lesions. They're going to start from the face. So there is the progression of the lesion of the rashes in case of mpox from macule, papule, vesicle, pustule, and eventually it will crust out. These are the complications of the mpox. In less than 1%, it can cause encephalitis. And so the DDs of mpox, which we need to take into consideration. So this is a chart which is showing all the common. Sorry. Okay, so in mpox, we typically see lymphadenopathy, which is not seen in chickenpox. In mpox, the lesions are in same stage. In chickenpox, the lesions are in multiple stage, right? And then measles, typically we see the coplic spots. And then in HFMD, the lesions are on hand, feet, and mouth. And on hand and feet, the lesions, palms and soles, the lesions can be seen in mpox, but they are not seen in chickenpox. So lymphadenopathy, same. So lesion in the same stage, number 1, lymphadenopathy, involvement of palms and soles, and centrifugal rash. These are the characteristic features of mpox. In chickenpox, we have lesions in multiple stage, right? No involvement or re-involvement of palms and sole, and it is a centripetal rash. So it is mostly when the monkeypox cases are on rise. So many a times it is misinterpreted with chickenpox. So the case after like 1st Jan 2022, since the cases have started, any unexplained rash with these following features can be a case of suspected mpox. And then eventually, probable cases, if he or she has some epidemiological link, or if there is multiple sexual partners, or we have IgM antibody positive, and then there's a positive result of positive with PCR. So in the confirmed case, we do the lab confirmed case, and the most commonly lab investigation we use are the real-time PCR. And this is very important for the MD students, what samples to take in the mpox patient. The lesion roof has to be taken with a plastic scalpel, and then after the roof have been removed, the lesion fluid, it has to be taken with an ID syringe. Then the base scrapings, they should be scraped with a sterile swab, and then the crust, the lesion crust should also be put in a plain tube. So these are not just rubbing the rash or rubbing the particular pustular area will not help. The roof, the fluid, the base scraping, and the crust, all these 4 things they have to be taken. So this is by the ICMR. The first of all, the PCR for the orthopox virus is done. If it is positive, then do the PCR for the mpox. And 2 steps should be taken from different locations. So next, coming on to the not lesser common, other disease is molluscum contagiosum. This is a benign disease. This is caused by pox virus. And this nodule, it is several fleshy lesions. They can be seen. These are umbilicated. They have umbilicated centers like this. These are molluscums. They are small, dome shaped. They are shiny. The bumps, they have a central dimple, and they can be pus filled. They can have a secondary infection. So they can occur on the hand. They are papillary regions on the hand. They can get into the large pustular regions also. So next is the HPV infection. The most commonly HPV causes the warts. So the papillomavirus, which produce human warts, these are the DNA viruses, and most commonly they cause the common warts, plantar warts, or the condyloma acuminata. So these are the warts most commonly caused by type 6 and type 11. And other types they can also cause the warts. So these are the pictures of the perianal warts and the vulvar warts you can see. So these are the flat warts. They are smaller. They are non-scaly and skin-colored papules. They can be seen on hand, neck, and face. So they are treated with the cryosurgery. So next, coming to the HSV, herpes simplex. So in HSV, the lesions, they are vesicular, papular, vesicles and papules, and the ulcers, they are also formed. These are the erythematous regions, and they are typically punched out. They are superficial regions, red and smooth base is there, and they may have the serous fluid. So these regions, they are itching, and they cause itching also, and they are painful. And along with that, there is a presence of the bilateral inguinal lymphadenopathy also. So the samples, now how the sample has to be taken. The vesical lesions, they have to be cleaned with the sterile saline, and then they have to be aspirated with the needle, which has to be inserted at the edge of the vesicle. Then aspirated material should be injected into the VTM, and then it should be rinsed twice or thrice, and then eventually we can do the PCR from this. And if there is some ulcer, that the ulcer, it has to be unroofed. Then the swab, it has to be taken from the base of the lesion, and eventually it has to be transported in the VTM. So usually Zanx it has low sensitivity and specificity. Then is the HSV DNA PCR, which is usually done for diagnosis. Yeah. So these are the main viral conditions which I have tried to cover. So any questions or any comments, please?
I think
I have overshot my time slot.
no, that's fine. I think we'll take the questions collectively at the end if it is okay with all the speakers.
Fine.
Okay, thank you for that very informative talk, Dr. Gursimran. And I just would like to add one point here. I think molluscum and HPV will not present with fever in many cases.
Yes.
Whereas,
True.
whereas rest of them will have predominantly fever as a symptom. Okay.
True.
Thank you, Dr. Gursimran. Now I request Dr. Shantala GB to kindly share her screen and give us perspective from the VRDL network, which has really helped us in the COVID pandemic, as we have seen. So Madam will share her experience from state level VRDL, and also how the case with fever and with rash will be addressed as such. Ma'am, please share the screen.
I request Dr. To just stop sharing the screen. I request the earlier speaker to stop sharing the screen.
Dr. Gursimran, could you please stop sharing the screen from your end?
Hope my slides are visible, Dr. Sneha.
Yes, ma'am. You're audible and slides are visible, but could you please put it in a slideshow?
Yes, slideshow. Yes.
Thank you.
Yeah. Good evening, everybody. At the outset, I would like to thank IMMKC President Dr. Nawaz and her team for this opportunity given. I also express my thanks to the chairpersons, Dr. Jayanti Savio and Dr. Shalini Shinoy, with the team from BMCRI, Dr. Sneha, Dr. Shweta, and Dr. Satyanarayan for this wonderful, and I applaud them for this wonderful initiative. So most of the things are covered by by the earlier speaker regarding the clinical presentations, the morphology of the rash and the diagnostic aspects of viral infections presenting with fever and rash. I will be just briefing I will be just briefing about the diagnostic approach that is taken up by state level VRDL BMCRI with also surveillance aspects of these viral infections presenting with fever and rash. So as discussed by the earlier speaker, the viral infections are the most common causes of for patients presenting with fever and rash. The most common viral infections associated are dengue, chikungunya, measles, chickenpox, rubella, HFMD, herpes simplex virus, human herpes virus 6, and parvovirus B19. Most often, the clinical diagnosis is insufficient due to overlapping symptoms among these cases. Though these conditions are self-limiting, some of the infections are associated with increased mortality and morbidity, like dengue and chikungunya. Laboratory confirmation is required for accurate diagnosis and public health management. Laboratory diagnosis can be achieved by microscopy, which has low sensitivity and specificity, viral culture, which can be attempted only in laboratories which have BSL-2 and beyond facility. So the mainstay of diagnosis of these infections relies on serology and molecular diagnostics. Serological diagnosis of these infections can be done either by antigen detection or antibody detections, that is IgM and IgG, by either immunofluorescence or ELISA techniques. IgM detection helps in diagnosing the recent infections, and seroconversion, that is between a fourfold rise in titers between acute and convalescent sera, helps in diagnosing these recent infections. Of course, for remote infections, we have to depend on IgG avidity assays. So molecular diagnosis involves PCR, wherein we directly detect the nucleic acid, and they are of utmost sensitivity and specificity. So though these conditions are self-limiting, laboratory confirmation is required. So why is laboratory confirmation required for these conditions? So the laboratory confirmation confirms the clinical diagnosis, identifies the viral etiologies that enables appropriate patient management and infection control, genotyping that is achieved by molecular diagnosis, further enables tracking of circulating strains and detection of novel variants. The surveillance data that is generated from these diagnostic labs can be used to estimate the true disease prevalence in the community. It helps in early identification of outbreaks, and also to develop strategies for vaccines by policymakers and stakeholders. The different array of diagnostic tests that are available at state level BRDN, BMCRI are IgM ELISA for measles and rubella, IgM ELISA again for chickenpox diagnosis. We do have real-time PCR for detection of VZV DNA. HFMD is diagnosed by detection of enterovirus and Coxsackie virus RNA by real-time PCR. Dengue fever is diagnosed by detection of NS1 antigen in the early phase of the illness. During the later stages, it is by IgM ELISA. Real-time PCR is used for detection of dengue virus RNA. All NS1 antigen positive samples are subjected to dengue serotyping. Chikungunya is diagnosed by IgM ELISA. Monkeypox, we use real-time PCR for detection of monkeypox virus DNA. For diagnosis of lesions caused by HSV, we have PCR, viral culture, and serological assays. The flow of samples is usually from the patients attending pediatric and dermatology OPD presenting with fever and rash. We do receive samples through surveillance network, that is district surveillance unit. After initial physical and systemic examination in the OPDs, relevant samples or appropriate samples are collected depending upon the type of presenting symptoms. The diagnosis is the diagnostic test that is used for diagnosis. It depends again on the clinical diagnosis. So after testing, the results are analyzed and duly reported in relevant portals, that is IHIP of NCDC and NIE portal of which is from ICMR. So this is our sample request form, which is quite comprehensive and user-friendly. This has details for both outbreak and individual patient-wise. Apart from demographic details, the sample is designed in a syndromic way. So fever, any case presenting with fever with rash, the doctor needs to only tick on the symptoms. So that way it's user friendly, and with this it also has epidemiological details to know whether there is a similar case in the household or in the community. So we have a separate section for outbreak samples as well. So these are the tests that were done from cases of fever with rash in the year 24-25. Majority of the cases samples were received from suspected cases of dengue, followed by chikungunya. For HSV, we did receive samples directly from the lesions, which were subjected to PCR. IgM ELISAs was performed for samples that were received with clinical diagnosis of measles, rubella, and chickenpox. For monkeypox, PCR was done. Here it is showing 50% positivity because we have received only 2 samples for the year 24-25, and one has been reported positive earlier this year. So that was about the use of tests for diagnosis of cases. VRDL lab was instrumental in confirming cluster outbreaks of varicella zoster in the year 23-24, where random sampling was done from suspected cases and referred to VRDL for IgM ELISA testing. Out of the samples that we received, we saw positivity in the positivity rates was up to ranging from 80 to 90% by IgM ELISA. Similarly, the lab did confirm outbreaks of mumps. Just a disclaimer, mumps does not come in the scope of infections, viral infections causing fever and rash. This is just to emphasize on the importance of laboratory confirmation in confirming outbreaks. So we did receive samples from suspected cases of mumps, and IgM ELISA testing was done. We reported around 60 to 80% positivity in these cases and confirmed these clusters and outbreaks. And the samples were received from different districts of Karnataka through district surveillance units. Just an update on WHO campaign for the laboratory-based surveillance of measles, rubella, and congenital rubella syndrome. This is an integrated surveillance program, WHO initiative, which involves case-based, population-based, national surveillance for measles and rubella with laboratory confirmation as the key component. Surveillance systems are designed in such a way to detect, investigate, and confirm every suspected case, enabling early detection of outbreaks. The unique feature of the network is a uniform standardized protocol is followed for sample collection, testing, and confirmation by all the laboratories in the network. The laboratory data, the genotyping and molecular epidemiological data that is generated in these laboratories is used to track the virus transmission. The member states report these data in the their portals, which is monitored by WHO to analyze trends, investigate outbreaks, and also study the vaccination impact. An update on monkeypox virus diagnosis at state level VRDL. The VRDL was identified as the testing site for Karnataka state in the year 2022 when WHO issued an alert for monkeypox. As discussed earlier, monkeypox virus is an enveloped double-stranded DNA virus that belongs to orthopox virus genus and poxviridae family. So the surveillance strategy was both hospital-based and targeted surveillance. The hospital-based surveillance usually was done on patients attending the healthcare facility with symptoms of fever, rash, lymphadenopathy, and with the recent history of travel to the endemic countries. The samples that were collected was swabs from the surface, floor of the vesicle, vesicular fluid, oropharyngeal, nasopharyngeal swabs, blood sample, which included both plasma and serum sample, and urine sample. All these samples were referred to the testing site, that is VRDL, for testing monkeypox virus DNA by real-time PCR. We did use real-time PCR for for detecting monkeypox virus DNA in these samples, and we have investigated around 30 cases thus far, and have reported one positive earlier this year. And this is the picture of the positive case, which shows positivity for orthopox virus DNA and then monkeypox virus DNA with the internal control. Just to reiterate the role of the network in detecting any genomic variants, we did analyze samples that were received for monkeypox virus, for varicella zoster virus DNA also. So we found positivity in these samples, and all positive samples that were tested, all samples which were tested positive for PZV were again further submitted for genomic surveillance. The most of the samples were belonged to clade 1 and 5, but there was detection of clade 9 for the first time in these samples in India. This clade 9 detection was first reported in India from our side, and this clade 9 is known to be prevalent in Europe and USA. So this signifies the necessity for genomic surveillance during outbreak investigations, and also to continuously monitor for varicella zoster virus diversity. So to conclude, laboratory investigation is required for accurate diagnosis and management of fever with rash. Molecular diagnostics and serological assay form the mainstay of diagnosis, and they provide results within quite rapidly. A robust surveillance network with laboratory support is crucial in analyzing the trends of these diseases in the community and identify outbreaks, and also study the vaccination impact. Genomic studies are relevant for variant identification and detection of novel virus. I duly acknowledge the support of ICMR NIV Pune, IDSP, and institutional support in this endeavor. Thank you.
Thank you so much, ma'am, for describing the whole process involved in addressing cases with fever and rash. And I think PGs and even the faculty from private medical colleges would have definitely, learnt about this network, because many of the government medical colleges have they have some exposure to VRDL network, but even others would have definitely benefited. And just to add another point, this network, as madam said, happens, the referral of the samples happens through IDSP network, and it's totally free of cost. So once the test request form is filled and the samples come to the respective labs, just like we have state level VRDL at our institute, there are medical college level VRDLs also in the rest of the medical colleges. So it's totally free of cost. Thank you, madam.
Yeah.
We next have our third speaker, Dr. Tanmaya Metgud. Welcome, Dr. Tanmaya. Dr. Tanmaya, are you there?
Hello.
Hello, Dr. Tanmaya. Yeah, welcome. Welcome to this masterclass PG session. And we have a few questions as microbiologists to a clinician, a pediatrician who has interest in infectious diseases. So, would you please tell us what are the common viral exanthems that you encounter in your clinical practice?
Yeah, most of the common, like first thing is whether the children are vaccinated or unvaccinated is the issue. Like in case commonest now is measles, then we see a lot of cases of HM, hand, foot, mouth disease. I mean, there's changing pattern of the presentation as well as this exponential increase of HMFD as compared to measles and this thing because of the vaccination status. Okay, then comes the dengue fever, like with the rash. And now, very sick children, we are finding even adenovirus in picture. Like we had a lot of, I mean, few cases where they were like rapidly progressive pneumonias with fever, rash, and rapidly progressive pneumonia, and acute encephalopathy syndrome, rapidly progressing. We suspected adeno, and even your PCR was proven with adeno. So that is also upcoming one of the exanthematous illness what we see nowadays.
Okay, yeah, thank you. So, do you see such variation every year, or is there a change in the pattern over years? Like you've been practicing for so long now. So, do you
Yeah.
noticed any change over the years?
Yeah, definitely we're seeing a lot of changes, like because of the vaccination status, like measles, almost children receive around first dose, around 92%, and uh, around 91% in the second, they complete their second dose. So they don't get typical measles, they get a modified measles. There, the fever duration is less, the rash is not that severe, and neither their prodromal symptoms are that severe, and they don't have complications much as compared to. So we get to see a lot of modified measles because their immunity over the years wean off. So it's not necessary that typical age group of less than 2 or 2 to 5 years. We see modified measles in the later age group. Now, because of the vaccine status, sometimes these modified illnesses are coming at later age group in adolescent and adults also. And the same thing with MR campaign, which was done by Government of India in 2017. Measles and rubella, almost all school-going children were vaccinated with one single dose of MR. After that, the incidence of measles and rubella is less, but we have sudden shoot up in mumps cases. So as madam was talking in the previous, these things, when they do the serology and all, it really helps in the policy making, whether they can include the moms also when they give the MR, when they do the vaccination campaign. We had very unusual presentation for moms also this time. We had hearing loss, we had nephrotic syndrome, very unusual presentation post vaccination status. Even the same hold true for the chickenpox vaccine also. We get atypical chickenpox if they are vaccinated. Like in usual children who are unvaccinated, the number of lesions will be more than 500, pleomorphic in nature, more than 500. Whereas if it is vaccinated children, winning immunity and they're exposed, they may get modified this thing where they will have less than 50 rashes and the intensity is less and complications are less.
Okay, so do you seek the lab support for diagnosing such cases, especially when the cases are atypical? So I would like to ask you this question, that what's the role of microbiology laboratory or investigation in these cases of viral exanthems?
Yeah, yeah. Like in, I want to share a case if permitted. Let
Yeah,
me,
yeah, sure,
I'll
please
take
go
it
ahead.
over. Mm. Okay, I'm not able to do that. I'll just share a case here.
I think you should be able to, we are able to see your screen right now.
No, I'm not able to.
Okay.
It's okay. We had a case of 12-year-old child presented to our ICU with history of fever and for 5 days, vomiting and headache for 3 days duration. And child had one episode of generalized clonic convulsion, and child also had history of blurring of vision and diplopia. So whenever we get a case of seizure and headache, fever history, we put it as altered sensorium. So the history-wise diagnosis will be acute encephalopathy syndrome. And further examination added that the child was tachycardic and had hypertension. BP was around 150/98, and child was in altered sensorium, could be post-ictal, and decreased air entry on the right side compared to left side showed evidence of clinically diagnosis of bilateral pleural effusion. So with this, we came to conclusion that this is acute encephalopathy syndrome. As it was fever with rash history was there, so we put it as acute encephalopathy syndrome secondary to acute viral exanthematous illness. And there was evidence of third space loss and hypertension. So third space loss again made us think towards dengue illness. And one thing which was not fitting one was hypertension. Usually in dengue shock and all, we usually get hypotension. So as there was hypertension, followed by which there was associated with convulsions, we thought of posterior reversible encephalopathy. Press. Okay, so in this, what the MRI also, your investigation showed hemoglobin of 12.9, count of 4,200, and platelet of 33,000. X-ray added pleural effusion bilateral, and USG Doppler of the renal vessels were normal. The molecular the NS1 antigen, as this was in the first 5 days of fever, NS1 antigen was positive, IgM was positive, and IgG was positive. And MRI showed that gyriform hyperintensities involving bilateral posterior parieto-occipital region, which usually is suggestive of press. Okay, so here the final diagnosis after all this was dengue press syndrome. And here the serology was also done for RNA PCR, and dengue serotyping was done, and it showed serotype of 2. So in this, we avoided doing LP because dengue virology was positive, and NS1 was positive, IgG, IgM was positive, and press MRI showed press. So it was due to hypertension. The child was put on anti-epileptic and antihypertensive, settled down. So definitely molecular investigation helped us to avoid LP and come to a conclusion that it was specific related with the dengue virus, and a typical presentation like press, posterior reversible encephalopathy syndrome. Nowadays, with ongoing antibody, because its disease has been so long that we get lot of antibody exacerbation, and we get complicated dengue or dengue expanded syndrome, what we call. We get acute optic neuritis, we get ADM, acute disseminated encephalomyelitis, and we get press. And these are the changing trend what we see in dengue. And the routine one, which simple dengue fever, they don't need much of treatment or any admissions. So that is a changing trend what we see over the years.
Okay, thank you. So definitely, as you highlighted here, microbiology and even other relevant supportive investigations do help you to, manage the case well, right? So can you please let us know how often do you write for lab investigations, and also how easily accessible or available are these, especially the molecular diagnostics
Okay.
with respect to these?
Usually most of the fever exanthematous illness group, what we call like, are a spot diagnosis for us, like especially the infectious group when we talk, like measles, your chicken pox, hand, foot, mouth disease. Routinely, if they're only with a simple presentation, we do not write any investigation. They're spot diagnosis and OPD based treatment. But definitely in case if they come with complications like pneumonia, if they come complications with aseptic meningitis, encephalitis, and a typical presentation, then we do ask for investigation. Most of the investigations what we ask are in IPD patients. We had hemorrhagic measles. So in those conditions, definitely we ask. Only thing what we find is a turnaround time. Like I was telling about adenovirus, this so rapidly progressed by the time we send the sample, and we being in the center where we have to send the CSF and the serology to Bangalore, the turnaround time becomes almost 36 hours for the sample to reach and the report to come. So for us, even the 36 hours, because the newer drug, cifidinor, which we use for adenovirus, is not even easily available. So if this becomes like more accessible and the turnaround time for the viral PCRs become lesser, probably that will help in managing our patients well. I'm not able to hear you, Dr. Sneha.
I was on mute. So as I could comprehend from what you said, you seek help only when you're not able to diagnose the cases clinically. Straightforward cases do not need lab confirmation all the time. However, challenge according to you is accessibility, because even in a city like Belgaum, finding
The reporting, the turnaround time for us.
time is still a challenge. Okay, point well taken. So, can you just let us know, like apart from turnaround time and what is other expectation as a clinician from microbiology or virology labs, so that we can, it is a take-home message for us as to how we can improve and help you to strengthen the diagnosis and manage viral exanthems better.
Yeah, like Dr. Shantala ma'am was telling, like we do report most of the cases what we see, like measles and all are reporting this thing, but actual sample collection, and you need to train us more like regarding what samples to send, and when exactly is the high viral load where you will get the sample positivity and all those stuff. Because most of the time we depend on your rise in titers of immunoglobulins, and rather than actually go for RT-PCR in most of the things. But complicated cases, we do ask for PCR test.
Okay. So improvising that and probably more input from our end as to when and what to collect and when to expect.
Yeah, and more of reporting, like what ma'am said, we do, but we just report the peak of the iceberg. We don't actually, the burden is too much. Like.
Right. So now we will open the floor for questions. I already see two questions here. One is by Dr. Adi Kulkarni, sir. So the question here is NS1 by ELISA and PCR, what is the percentage of discordance? I think this question is for Shantala, madam.
Yes, there is discordance. So not all NS1 positives will be PCR positives. There can be several reasons. Presence of any PCR inhibitors can hinder the detection of RNA directly. So NS1 antigen is a better test for diagnosing the dengue fever. PCR we do mainly for qualitative PCR, we do only those tests which are positive by qualitative PCR will be further subjected to serotyping. So we need to know serotyping to have a general idea of distribution of the serotype in the geographical regions. And some serotypes are associated with complications, especially serotype 2. And if the primary infection is with one serotype and the secondary infection happens to occur with a different serotype, the complications are more.
Okay, thank you. I hope that answers the question. And there's another question which uh, regarding performing serotyping for dengue NS1 positive samples. So the question is whether it directly benefits the patient or is it only for academic interest?
It is for epidemiological purpose. We need to know the distribution of serotypes in the geographic region so that it will help us in analyzing the results of ELISA test and also analyzing better management of the cases.
Okay,
And
thank
for
you.
us also, it's important to know, like in HFMD, the shift of from Coxsackie to herpes, your this thing, enteroviral, it is helped because the distribution pattern is a bit different and it is more severe in this thing. They had a study from CMC Vellore also, I think, in 2022 out, where they mentioned about the shifting trend of the virology pattern in HFMD. It matters to us also, like in that case of complicated dengue with that serotyping, it helped us why this child had more complication.
Okay. So not only for epidemiological purpose, but in addition, it helps the clinical management also in some scenarios. Okay, the next question here is, do we have a KHPT-like network which can cater to faster transportation of samples and hence earlier diagnosis? I'm not sure what KHPT-like network means. Can you please unmute yourself and ask the question? Dr. Sulaiman?
It's regarding like just like we have for TB diagnosis and NTEP. KHPT is the connecting link which is going to collect the sample from the peripheral centers, bring it to a common nodal center where they perform the CB-NAT test, TrueNAT, etc., and then deliver the report. Like that, I was asking if similar such network is available who can transport and help in early diagnosis.
Okay, I think Shantala madam can answer this question.
No, I'm not sure about that network, but we do have a strong, robust surveillance network that is through IDSP. You can as well approach the district surveillance units, which will help in whatever samples that are collected by the clinicians or the laboratory people are shipped to the nearest medical college VRDL or state level VRDL for testing. So district surveillance units can be approached.
Okay, thank you. So next question is about multiplex PCR for fever rash, which is commercially available, like QIAstat fever rash panel. Dr. Gursimran Kaur, probably you can answer if you have any experience with commercially available multiplex PCR kits.
Yes, ma'am. I personally don't have any experience. The kits from True PCR and some available for the fever, but fever with rash typically covering all the viruses which we need. I'm not sure about that. We have not used that.
When we ask for flu panel, madam, for this thing, we get so many positives. So we'll not know actually which is the commensal, and that also becomes an issue when influenza and para-influenza, most of them will come positive. So our experience is bit this thing when we ask for flu panels when
Yes, true.
in this commercial panels is the one difficulty what we face is multiple things are positive.
Yeah, so even if you're using a commercial panel, probably unless you add clinically relevant notes, which the clinician can comprehend and use it to their advantage, probably it won't be of much help. Another question here is, which ELISA or chemiluminescence or alpha-based kits help private labs in cost-effective diagnosis? Dr. Tanmaya, you probably being from a private setup, I think yeah, if you have any exposure in. So, okay, we are not aware of such kits as such here. The next question is, reason chikungunya is increasing in the last few years, and how does it differ from dengue specifically is the question.
In pediatric, we don't get that many cases of chikungunya as in adult, but in adult it is increasing. Only thing the joint pains, joint swelling are more this thing, and the disease prolongation is more. Like in pediatric, what we see is the neonatal presentation. If the mother has got chicken pox and the baby presenting at neonate period with rashes and this typical scarring is what we get to see more rather than chikungunya specific in younger, like less than 5 years age group.
Okay. Thank you. So another question here is, in case of measles, nasopharyngeal, oropharyngeal swabs, urine and plasma to be tested for real-time PCR. Are they done individually or can it be done in a pool? If there is especially discrepancy in various samples, how to approach final reporting? So do we pool and do it, or do we do it individually is the question. Dr. Gursimran, I think.
I will just give a clarity on how to proceed for measles as well as for the rubella samples. So number one is that we do the IgM ELISA. So IgM ELISA, so we have a Euroimmun ELISA. If it is positive by Euroimmun ELISA, we have a more sensitive ELISA, that is the microimmune ELISA. If the history
Your voice.
triplicate.
Madam, your voice.
Hello.
Yeah, now you're
Hello.
on.
Yes,
Yeah.
the sample it is put in triplicate, right? So we have one sample which is put 3 times. So we take best of these. Well, if 2 is positive out of these 3, we take as positive. If 2 are equivocal, then we can repeat the sample if the patient may have given the sample earlier in the stage of the disease. So this is about the IgM. Then we can do the IgG, in which we have the 4-fold rise. And in case of rubella, we also do the avidity test. If avidity is low, that means there is a recent infection. So, am I audible? Is it fine?
Yeah, you are
Hello?
audible.
Yeah.
Yeah, you're audible.
Okay. And then the PCR. In PCR, we cannot pool the samples because this is not like COVID. Like there are many cases, so we can pool and then we can again test it again. So these are very important patients. All the patients in which we get the positive ELISA, we do the PCR. In nasopharyngeal, throat, whatever samples we get put different PCRs. And similarly, if we are having some discrepancy, one thing is that we put the PCR only when the ELISA is positive. So most probably it has to come positive only. So if still there is discrepancy, what we can do best is that we can ask for the repeat sample, because there are chances that the patient has given sample earlier. So there is no pooling, and then we can put the sample in triplicate. This is the way we can see that the results are fine. And a very important thing is that we need to take history of vaccination, recent vaccination. That may give the false positive result. And then how many days measles PCRs can be positive. So we say that when the patient is having rash, the sample has to be given at that time. So if within 3 to 5 days, we prefer the sample should be given. So if there is like after 10 days, the positivity decreases.
Okay, so whether it is plasma, urine, or the nasopharyngeal or oropharyngeal swabs, if it is given
They have to be
the rash, the positivity will be high.
fine.
Okay. So one more question here is importance and interpretation of NS1 versus IgM in dengue. I think this was already told in the during the talk, but I think for the benefit of the audience, it can be repeated.
This NS1 can be tested during early stages of infections. Best results are achieved if the test is done within 5 days. More than 5 days, it is better we go for IgM antibody testing.
Yeah, and other related question here is diagnostic significance of IgG and IgM ratio in identifying secondary dengue.
Yes, this ratio plays a role in identifying secondary dengue when the kit that we use is of the same company, and we detect IgG and IgM. The values are given, the ratio that we get, there is a cutoff for this in identifying both primary and secondary dengue. Yes, it can be used, and preferably we use, I'm not promoting PanBio here, using PanBio kits, we can differentiate primary and secondary dengue infection based on IgG and IgM ratio.
Okay, so any specific cutoff, or it's just calculated and interpreted?
I don't remember exactly the cutoff, but we have done the study a few years back. We can get back on this. The details we can share it during later part of the talk of the session.
Thank you. And another question is about SSPE. They want to know about the serological diagnosis of SSPE in serum and CSF.
Ma'am, in SSP, as rightly written, both serum and CSF IgM we have to do. And then in the CSF IgM level, they have to be higher. So we get very less. I think I've never gone through any case of SSPE. So, but like in serum and CSF, both it has to be positive. The ratio, if it is any, I'm not very aware, I can just get back to you. But this I'm sure in both the samples we have to do it.
Okay, so, okay. Thank you. So any further questions? Okay, so we can conclude the symposium, and I would like to thank all the three speakers, Dr. Gursimran, Dr. Shantala, and Dr. Tanmaya, for taking your time out and enlightening our audience here. And I would also take this opportunity to thank our office bearers of IIMMKC and the masterclass series as well. And in addition to that, thanks to Dr. Sudhindra for taking the initiative from North Zone and Central Zone, sorry, and helping us to arrange this talk. And also thanks to Dr. Shweta for giving her inputs regarding making it a symposium with three speakers in one go, and helping our PGs to give different aspects. So, and thank you all for real active participation. And we hope to meet again. That's on the fourth Friday of this month with the new session and new speakers. And definitely recording will be made available. Thank you. Thank you, everyone.
Thank you, Sneha.
Thank you. Thank you,
so
Sneha.
much.
Thank you for the opportunity.
Thank you.